Good afternoon, everyone. It's been a great conference. I've had to revise my slides because we've seen a lot of different things. So there's not a lot of graphs in here, and hopefully that's a good thing for you guys. You've seen enough. All right.
Big green button.
Big green button. Okay, no disclosures today. Learning objectives. So it's just me. My partner bailed on me. He had a family emergency, so that was Dr. Dan Bebo, great guy. So we'll skip him and go right to me. So I've been in the field for about 17 years. I've done a lot of different things. Those are some of the settings that I worked in jail, schools, prison, residential, outpatient. And the reason I mention all that stuff is I have a different perspective. I like to think a lot about systems. And then I've developed a bunch of treatment programs, some of them including MAT, and most importantly, I look a lot like Chuck Norris. Okay, so this is what we're going to do today. We'll go through a little bit of history. We'll get into doing some outcomes, and we'll get into some organizational policy related issues and some specific client considerations. So to start us off, you were looking at Colorado's first two ring ninjas. So this was one of the happiest days of my life. These are my twin nephews, and they were at my wedding, presenting my rings. And I'm going to tell a brief little story about, oops. How do I get the laser thing? There we go. I'm going to tell a little story about this guy, Noah. So these guys were twins, and they were about 6 years old, and there was a new house, and my sister and brother-in-law decided, they were going to move. And everyone was excited about the new house except for this little guy, Noah. And they talked to Noah and asked him, what his deal was he worried about moving? He was saying weird things like, I like the kitchen tile in our old house. The new house they were moving into. So upon further and further explanation, they sat down with Noah one day, and Noah said, the reason I don't want to move is I don't want to have to leave all my toys behind. He thought he had to leave all his toys behind. So, we explained to Noah that wasn't the case at all. He could bring his toys, and what ended up happening, he moved and loves his new house. And so the relevance of that story, think a little bit about medication-assisted therapy. And our patients or our clients, I'll use those words interchangeably. So I'm in a hospital setting now, so they're clients, a lot of you, or they're patients, a lot of you might call them clients. But they're moving through a continuum of care. And there's a lot of implications, and we're going to go into detail as to what some of those are. So we'll start off with looking at the history. Somebody else presented on this a little bit, so I'll try not to go too deep, but take about 10 minutes. So 1800s. So, you guys have all heard about Freud and cocaine. And every picture of Freud I've ever seen is dead serious. He never looks like he's on cocaine. Just saying. Also, can you imagine going into his office, laying down on the couch with your back to him, being on cocaine? It would just be crazy. However, right, so 1800s, lots of different drugs were in use at the time. They had medicines including, opium, morphine, etc. 1900s, we get to some real pejorative language. Some states passing laws about sterilization and defectives. Harrison Act, Supreme Court. So physicians are beginning to get in trouble for how they're practicing around using specific medications. 20s. So the bottom one, the Journal of Inebriety, I can never say it. It's like a sobriety test. But the Journal of Chronic Drunkenness, they don't publish that anymore. We start to see narcotics disappear from medications. The government's cracking down. 30s, we're seeing the federal narcotics farm opening up. It's a picture of the federal narcotics farm in Kentucky. Bill W. rolls up on the scene with Bob. AA. Beginning to see a little bit more research. 40s and 50s, Minnesota model, we're all very familiar with that, I hope. We're beginning to see antabuse being used and other drugs experimenting with around addiction treatment. 50s, we're starting to see a definition of alcoholism from AMA. Veterans Health is beginning to open up treatment centers in their network. 60s, we're seeing hippies and the American Bar Association partnering up with the AMA really beginning to look at the issue. Starting to see some funding coming around. We're starting to see the use of methadone blockade therapies. 70s. So this is where we're beginning to see a shred of parity. Insurance companies really looking to cover treatment, FDA-approved methadone. 80s, Miami Vice, cocaine, research nicotine patch, UCLA. So 90s to now, this is where a lot of stuff happened. We just did a whole lot of this in the conference, so I put it all into one slide. But you know, we're beginning to use different medication-assisted therapies for different things. And so today I'm mostly talking about buprenorphine. So this is where I cut a bunch of slides out about the efficacy of MAT because we've seen a lot. So I just have a couple slides that I'm going to go through on that one. So this is Baltimore, or I'm sorry, yeah, this is Baltimore. No, next one, Baltimore, I'm sorry. This one basically is a study about 600 people using opioids and then initiating treatment over, I believe it's 48 months. And so we see as people get on medication-assisted therapy, they're having better outcomes. At the end of this 48 months, about 10% of folks are actively using prescription narcotics. Here's Baltimore. So we're looking at heroin deaths, right? So when we use MAT, people die less. We've seen this. This is a Baltimore study looking at use of methadone and buprenorphine. So we've heard lots and lots of compelling evidence so far at this conference, and I haven't heard anybody yet say that, you know, the preference is one or the other. The consensus seems to be that we want to see the M and the T, right? So it's medication-assisted therapy. So just a little summary of that. So now we'll shift gears and start looking at some organizational issues. So as we're helping our patients transition through levels of care, let's look inward first at what we're doing and see how that can inform us helping these folks transition through those levels of care. So as Doug mentioned, I finished my MBA. I mentioned that because every profession I've talked to, nobody has a standard like leadership or change management component of any kind of program. So I'm going to take a second and go into some of this business stuff because I think that you'll find that it's very, very relevant. So the reason I went and did the MBA, I'm a clinician by trade, been doing it for a while, and I started getting really frustrated with gaps in treatment services, particularly around funding. There's lots of great programs and things available if you can afford it. And many of our patients or clients can't afford services available to them. So dove into the finance. That's a story for another day. But bringing this change management piece, this was something that one of my favorite parts of the program was looking at how organizations change. And there was a famous business writer named John Connor, and he came up with this model of change management. So I'll just walk you through it briefly. It's common sense, it's not rocket science, but whether your organization currently is using MAT or you're transitioning to or from or whatever, these are all relevant things for us to look at. So creating a sense of urgency, right? What's the burning platform around why we do or don't do something? Forming a powerful coalition, right? Good, long, sustaining change. You need champions to identify within your organization to help propel things forward. And then you need to create a vision, right? We're visual people. So that coalition, you communicate that vision to the bigger organization, and that's where you really start looking at power in action, right? So change doesn't happen in a bubble. We need to include the people that we work with in carrying out this change. It can't just be these core champions that you started working with. Creating quick wins, so the relevance of that. People need to have hope. They need to see that things are working. Medication-assisted therapy, man, this has been slow going. It seems like change is taking forever around here. I'm not seeing a whole lot of quick wins, just generally speaking with our industry. But organizationally, that's what this is referring to. And then lastly, building on the change and making the change stick. Especially if you're working in a bigger organization, you know how challenging communication can be, right? It's unrealistic for me to send out an email announcement to 1,000 people and think more than 10 of them are actually going to read it and implement it, right? So that's why we have different ways of communicating. So making change stick, that varies from organization to organization. But what we're going to talk about later today, just please consider that as well. So, setting expectations. So, when it comes to MAT in your organization, what expectations do you have for the people that work with you or for you or however you want to put it? So that means a lot of different things. One thing could be around particular workflows. So who's involved in MAT? Is it just a prescriber? Is it a prescriber and a counselor? Is it a treatment team? Where does the administrative staff fall in with respect to MAT? These might seem like basic kind of things, but it's going to come up over and over. And having your organization align around how you do or don't use MAT is critical. Explaining the why, we talked a little bit about that earlier with the change management stuff that you just saw. But most organizations, you're going to experience turnover. People are coming from all different places. They believe a lot of different things. It's unrealistic to think that you're just going to come up with some great interview questions and you're going to hire all the perfect people and they're all going to be in line with what it is that you're trying to accomplish. You got to explain the why. Why is MAT relevant? We just had a whole conference on why MAT is relevant. But yeah, so continue with the why. And then lastly, the education of the staff regularly dovetails with what I just talked about. But how relevant and important is MAT in your organization? Does it warrant having regular competencies? Is there knowledge that people need to have that's so critical that everyone has to have the same message? Is that something that you're doing regularly? And it could just happen in your practice. Maybe you have a multidisciplinary team that meets every day, and it's just really, really ingrained. Or maybe that's not the case at all. And then lastly is staff MAT use. So what does that look like in your organization? Right? It's illegal not to hire somebody because they're on MAT. However, if somebody's impaired, it's a whole different scenario. And I'm not talking about safety-sensitive positions. But what policies do you guys have around MAT with your folks? Are staff encouraged or discouraged from self-disclosing if they're on MAT? These things come up. It's good to consider them on the front end. So here's a dissertation from 2016 that I thought was pretty interesting, and it gets at implicit bias. So in this particular study, they had about 250 providers and about 200 patients. This was in Washington State, and they got them all together and they surveyed them over a course of treatment. And what they were specifically looking at were the attitudes that the people involved in the patient's care had in the patient around use of MAT. So in this particular instance, right, so we're looking at family members, sorry, it's going to take me a minute to get used to this thing. There we go. Oh. So family members, 54% of family members pressured the patients, to get off MAT. Medical providers, 43%. Friends, 43%. And counselors. So this was like a pretty big push. Then CPS, Child Protective Services, so their workers, 36%. And probation officers, 34%. Any probation folks in the room today that's willing to admit it? Probation officers for the win. All right, so next, they asked CDP's chemical dependency professional. So they asked medical providers and chemical dependency professionals about their views on MAT. And only 5% of chemical dependency counselors said that they were against it. But when you delve deeper, kind of like what my sister did with Noah about why he didn't want to move, they found some reservations, 36 versus 13% for the docs and the counselors. And then same thing with complete support. They flat out asked them if they completely supported it. 80% of physicians versus 43% of chemical dependency professionals. So just a reflection of some implicit bias. So now let's shift gears and talk a little bit about some policies and protocols specific to your organization or the organization that you're intending to refer your patient to. Refills are the biggest headache when you're standing up an outpatient medication-assisted therapy program. And I'm not talking about OTP. Refills, a lot of different ways. My wife kind of jokes, she's in probation and parole, and she said it's amazing how many people lose their Suboxone on the bus. Because folks are accountable for their Suboxone, particularly if they're involved in a problem-solving court, like a drug treatment court, or they call them recovery courts as well. So the logistics around how refills work, regardless of why a patient might need an early refill, it's going to happen. And if you don't have solid infrastructure in place to support it, you're going to run into trouble. So this is what usually happens. When a patient, for whatever reason, runs out of a script early, the first thing they do is they call the treatment center, the organization. They don't talk to the doctor, right? They're talking to the administrative staff, a reception person, right? And that person gets the message and they pass it on to a nurse. And the nurse gets the message and passes it on to the provider. So you have this telephone game going, right? So we have our least skilled clinical people are the front lines, they're the one answering is the phone having the call. So as you can imagine, it creates a whole lot of conflict. So if you have a clearly defined refill policy that's set up in place in workflow, you're going to save yourself some trouble as well as the patient a lot of trouble. And there's therapeutic reasons why you want to have a good refill policy in place. Some places are using contracts. If you're going to engage in treatment, this is what it's going to be. So visit frequency oftentimes is something associated with a contract. So we'll see providers, they'll say, I'll only refill when you're in my office during your visit, period. And then we'll have other prescribers who might have a different way of looking at it. I'm not saying anything's right or wrong, but I'm just saying making the expectation clear is really helpful. So, the administrative staff, answering the phone, if they can stand on, can't help you unless you come in for an appointment, that's a lot easier than playing the telephone game. Other substance use. So what does that look like in organizations, right? So especially when pot became legal in Colorado, we saw more people smoking pot. And for MAT, some providers had really, zero tolerance policies. Other folks seemed a little bit more liberal about it. It varies, but whatever it is, having a good policy in place and knowing what you're going to do is helpful. And that kind of segues into the next thing about cross coverage. We're all entitled to PTO or vacation, right? So what happens when the prescriber goes on PTO? Who's covering? Someone's probably going to cover, but what if they have a different kind of set of rules? So that can be super helpful to make sure that everyone's on the same page with regards to refills, visit frequency, other substance use, etc. And then the last thing Dr. Beagle wanted me to make sure I shared with you all was about the scope of visit. So when we think about people that have been using opiates for a long time, they tend to neglect lots of different parts of their life, right? Physical health, mental health, etc. Dental pain is a common one that comes up a lot. So addiction, medicine, and treatment providers oftentimes will find the patient will show up for a visit and they'll end up getting into a bunch of other medical issues that weren't necessarily the reason they came for the visit in the first place. That's good, but that's time consuming, right? So it's important for our providers to define what the scope of the visit is going to be just for time purposes. Because I can't have my docs running an hour and a half sessions when they're supposed to be a half hour, right? There's other patients that they're not seeing. So defining the scope of the visit, it's operationally insufficient, but it's good so the patient will know what to expect. It also could be a good learning opportunity to help get the patient engaged in primary care or other specialty care as needed. Okay, you get a break. We're going to do a 1-minute intermission. This is for all my ADD brethren. Take a break, stretch. I won't talk for a minute. Good time to escape if it's bad. Get some coffee.